to decide what to say. For me, there's a lot of debate in the literature about what to say when you have a stenotic cochlear aperture. For me, what I do is I look at the MR, I look at the 8th nerve, and I see whether there is an 8th nerve coming off the cistern. Entering the cistern lah. So if I don't see that, then I would tend to favor calling it cochlear nerve aplasia. But if I do see a nerve coming off the pons, but just not the cochlear nerve itself, then I'll probably favor saying that there's severe hypoplasia or hypoplasia of the cochlear nerve itself. So that's what I tend to do. Because a lot of times, when structures are so small, they are known to be below the resolution. So in other words, current technology cannot resolve the structures because they are just so small. But we rely on seeing the bony structures and try and give a best guess, as it were. Alright, so this patient had a very stenotic cochlear aperture. And you notice also this is the vestibule, and there don't seem to be any canals around it. So the semicircular canals are aplastic or dysplastic. Okay? When you see semicircular canal aplasia or dysplasia, like this, like just the vestibule there, and patients often will have sensory hearing loss, they often have cochlear nerve hypoplasias. There's a syndrome you should think of. I'm sure there's other clinical stuff that I'm not aware of, but this is classic of anybody? Charge syndrome? Yeah, they have all the other clinical features lah, which being a radiologist I wouldn't know. But if you do see semicircular canal aplasia, it's a common sign in Charge syndrome. So this is a normal lateral canal, there's the vestibule there, and that's the posterior canal, and a little bit of fovea of the vestibular aqueduct. They often have cochlear aperture stenosis, sometimes also IC stenosis. Very common to see those. Okay, I think I'm actually done. Alright, so 8:45, yes. Okay, should I go straight in to the next one? Yeah? Okay, good. I can see you guys are still alert. Okay, for the next lecture, I'm actually going to talk about how to read a paranasal sinus, okay? So I'm going to start that by showing you a paranasal sinus, CT, and I'm going to straight away tell you that this patient has a lot of things to look at. So I'm going to show it to you before the lecture, and then after lecture also I'll show it to you again, and we'll see whether you see anything extra at the end of the lecture, which would mean that my lecture is either very bad or very good. Okay, so we'll start with this patient. So this is a multiplanar reconstruction. So the plane that I usually use is the coronal view. Now, when all of you graduate and become famous surgeons, right, you often go to a hospital where maybe the radiologist will look at axial slices, because to be honest, that's how we were trained. That's why we will tend to look at axial slices first. But in my experience and being taught by surgeons here, coronal view is actually more informative. Because in a sense I understand why, because you're trying to imagine that you are an endoscopist and you're going through the nose. So that's why coronal views make sense to you guys. And I do agree, it actually shows a lot more information than axial view. Having said that, because we are radiologists, the MPR does show us sometimes other things a little bit more clearer. But if I were to be asked which is the one plane I will keep, it's obviously the coronal view lah. Yeah, but there are times when the axial and the sagittal view have its own uses, because the paranasal sinus is after all a three-dimensional structure. Okay, so for the purposes of this, I'm going to actually use the coronal view. Okay, so I'm just gonna scroll through and you just see what you can see lah. Sorry, I'll get that out of the way. Great. So put up your hand if you saw one anomaly. Huh? What? Oh, okay. Put up your hand if you didn't see anything abnormal. Okay, put up your hand if you saw two anomalies. Okay, so let me tell you that there's more than that. There's actually more than that. Yeah, this is a really good case. But let's do the lecture and then we'll see whether you can spot some of these things, okay? So, okay, so obviously when a paranasal sinus CT is requested, usually it is because the patient presents with symptoms, or there's a plan to do FAST in these patients. So for me, or at least in the literature, there's many ways to decide how do I report these paranasal sinus CTs. So one of the ways is to follow this, which is known as SSACS. I think it's quite catchy because it sounds like something else that we all enjoy. So first of all, there is sinus opacification. That means which sinus is opacified is definitely the one thing that I want to talk about first. Then we will need to look at sinus drainage pathways. By that I mean the OMCs, and then the frontal ethmoidal, so the frontal sinus drainage pathways, the sphenoid drainage pathways as well. Then anatomic variants, critical variants, i.e. variants that are critical to surgery. So what I mean, the difference between the two is that the anatomic variants are variants that don't really matter so much to the surgeon, but critical variants are the ones that do matter. Then probably you can have a look at the soft tissue as well. Now again, I need to explain to you that when you all become famous surgeons, you probably need to educate your radiologists on on how to look at these things. To be honest, this is paranasal sinus CT among radiologists is not taught very well sometimes in our syllabus, and a lot of them will just, and prepare yourself for this, a lot of them will just report pansinusitis. Any of you who have worked in locums might know this. So, and they are not aware that actually the disease reporting is important, but what's probably more important is that we mention the variants. That's something you probably will have to educate your radiologist later. Okay, so I won't spend too much time on sinus classification. So obviously, if I see patterns, then I'll mention lah. So for example, maxillary sinus that is opacified, there appears to be something that's bulging into the nasal cavity. Obviously, sometimes you see bony changes that look like mucocele, and then you sometimes see all this thickening that's due to chronic osteitis, and so it tells me that it's a chronic process. Sometimes you see air fluid levels in more acutely ill patients. You may also see hyperdensity of the opacification. Now, hyperdensity in itself, there are three things that can explain it. So it could either be inspissated secretions, or it could be blood, or it could be fungal material. So depending on the history of the patient, one can decide what it is most likely to be lah. So I would say that obviously in a setting of trauma, you know what it would likely to be. But if the patient has certain symptoms and you see a very classic expansion of the sinuses with often a very hypodense mucosa around it, not quite like this one. I don't know if I look at, yeah, like this. You see this kind of hyperdensity and a little bit of mucosa around it that's hypodense. In the right patient, you may be able to suggest fungal material. Like, can you see here that even the ethmoid sinuses are grossly enlarged, and the sphenoid sinus has like a lateral canal there. A lot of hyperdense here, and I think the patient did have symptoms that fit to this pattern of. And on MR, in fact, interestingly, you will see areas that are hyperintense, which indicate fluid, but also some areas here. This is the same patient. It looks like there's material there, but on MR, it looks like it's air, but actually it's low intensity because of the dehydration of secretions by the fungal material. So, but yeah, it's not always easy to make this diagnosis, and probably may not be a radiological diagnosis in itself, but in the right context, you can suggest that this is what's going on. Okay, then intrasinus calcification is something that is also very interesting. A lot of radiologists will tell you, oh, okay, straight away, if I see calcification, it must be fungal, because we are taught that mycotomas calcify. But in actual fact, you can get calcification in non-fungal infections. And there are papers that talk about the patterns of calcification and whether or not, they will tell you that it's fungal or not. Mainly, I would say that if it's central and it's very small and punctate, the articles do say that that tends to favor fungal, whereas more peripheral and more like coarse-looking calcification is often non-fungal. But it is not a hard science. So yeah, just something that we may or may not see. Of course, sometimes when you get opacification of the sinus, you want to look for a cause. So if it's a unilateral maxillary opacification, you may sometimes see a cause which is odontogenic. So in this case, there was a periapical cyst, and you can see a little bit of the essence there of the bone. Yeah, this patient indeed actually was confirmed to have fungal mycetoma and also had a oral antral fistula. So you can see that there's no bone here and there was fistula to the oral cavity. Yeah, in some cases, you may see what this is, like a soft tissue at the orbital apex. And it tends to be associated with some disease in either the posterior ethmoid or the sphenoid sinuses adjacent to it. In this case, you can see that there's a lot of bone generalization here. This soft tissue at the orbital apex will cause the expected symptoms and signs that you see in this condition. And I'm often asked whether this is tumor, which is sometimes very difficult to say, but most of the time it is an infective lesion in my limited experience. Okay, so let's go to sinus drainage pathways and variants. So this is the more important bit. So when we look at a perennial sinus CT, so the coronal view is best for the OMC because you can see all these things there. And you all know what all these things are, so I won't go through that. Now, if you need to look at the frontal sinus drainage pathway, in actual fact, it's easier to see it at the sagittal view because it somewhat goes anterior to posterior. So here is the frontal recess, and then this is a very large agonized cell. It doesn't show the entire pathway on this slide, but it is often easier to see it in its entirety on the sagittal view. I will also say the same for the sphenoethmoidal recess, not really seen in this slice, but it is often easier to see the sphenoid ostium and the sphenoethmoidal recess on a sagittal view. So if I need to see those things, then I would probably go to the sagittal view. But the coronal view is best to look at the OMC. And you can actually sometimes make a decision about the frontal ethmoidal recess or the frontal recess on the coronal view, but it's probably better to look at the sagittal view. Okay, so I'm just gonna skip this. So this is the most common thing that you may see. So concha bullosa, often asymmetric, often can be associated with deviated nasal septum. I think this is quite basic for you guys, so I will not spend too much time. In this CT, you can also see that there is antennae process pneumatization, and the fovea ethmoidalis has a rather strange slope in this patient as well. So that's olfactory faucet there, cribriform plate. So here is apparently another kind of pneumatization. If the pneumatization affects more of the middle or upper part of the turbinate, it is known as the interlamellar cell of Grunwald. Okay, but yeah, up to you lah to decide whether that's important. Right, so here we see a nasal septum that's deviated to the left. There is also a nasal spur here, and you can see that usually the convexity of the turbinates are towards the septum, right? You notice that this is convex outwards. Do you see that? So this is an example of a paradoxical middle turbinate. It can, in certain cases, narrow the middle meatus or even deviate the anterior process. So in this case, this paradoxical turbinate has caused some deviation of the anterior process. You can see that the ethmoidal infundibulum is a little bit narrowed here. Okay. Yes. So here we have the anterior process that is pneumatized. Okay. Can you see those two things there? So they should not normally be pneumatized, but very, very rarely they can be pneumatized. And if they're large enough, they can cause some obstruction to the nasal cavity. Okay, now this one is, okay, so you can see that there is some fasciculation of the right maxillary sinus, okay, a little bit of the ethmoid as well. And you can see that there is something here. Does anybody know what that is? Haller cell?
Yes.
Yeah, okay. So this is a Haller cell that was diseased, and maybe it can be argued that it caused some mucosal thickening next to it, and there was some disease that ended up happening in the maxillary sinus. So on another patient, you can see no disease, but you can see the Haller cell here. So these are known as infraorbital ethmoidal cells. So yeah, there's a lot of bubbly secretions there, Haller cells. So they can, if they're quite large, narrow the infundibulum, ethmoid infundibulum, okay, or they can compromise the maxillary ostium in some patients. Bilateral Haller cells in this. Okay, then yeah. Sometimes you see nasal septal spurs, and these are quite easy to pick up on both axial or coronal slices. And you can see that, yeah, it would, if large enough, cause some degree of narrowing of the nasal cavity. This is a patient just now with the paradoxical middle turbinate. So often they are at the junction of the perpendicular plate of ethmoid and upper vomer. Yeah, and they can displace the middle turbinate or narrow the middle meatus. Okay, so this is a nice schematic diagram to show you the frontal sinus drainage pathway. So it's quite interesting because there are two compartments to the FSDP. The superior compartment is kind of more funnel shaped. It's at the bottom bit of the frontal sinus. And it sort of funnels towards the inferior part, which is the more canal-like part of the FSDP. And because of the way in which it tends to, orientate in this way, somewhat anterior posteriorly and in a slant, it is easier to see this on a sagittal view in either one or two slices. So you can imagine on a coronal view, you would need to actually move backwards and forwards to actually see the entire FSDP. But on sagittal view, you can see the whole thing, as it were. So remember that in front of the inferior part of FSDP is the agonized cell. Behind it is often the ethmoid bulla. And if these are diseased, you can also cause obstruction to the FSDP and some disease in the frontal sinus. So this is a nice view. You can see the FSDP there. So that's ethmoid bulla, and these are agonized. Well, this is an agonized cell, and that's probably a frontal cell. So that's agonized cell. That's a frontal cell. That is the inferior part of the FSDP. And okay, and so there's this classification for frontal cells that has been described, the Kuhn classification. In essence, if the cell is singular and is entirely outside the frontal sinus, it is 1. If it's a bit larger and maybe going inside towards if it's more than 1, it is 2, I believe. And then if it's somewhat encroaching into the frontal sinus, it's 3. And if it's really quite mostly occupying or located inside the sinus, then it is a 4. You can see how much disease it can result in. There are sometimes some of these variant anterior process attachments. I think the one that I would talk about is okay, so this one, the answer process is attached to the skull base. So you see that the answer process is attached to the skull base. Okay, and so the frontal sinus drainage pathway in fact includes the ethmoid infundibulum. Okay, and because of this, if you get any disease that is in the maxillary sinus, it can actually lead to disease in the frontal sinus. This is a variant that I haven't really seen myself, but it's one that has been described. Then in this one, the answer process in fact is attached to the lamina. So this is lamina here. So its answer process is attached to lamina. And so there's kind of like a blind pouch here, but it's basically the ethmoid infundibulum is in a way separated in a sense. So this is another variant that has been described. You can also, within these are the frontal sinuses, and the intersinus septum can also have a cell there. And if that's pneumatized and gets large enough, it may involve the cryptogallei, may even cause some disease, may impinge on the FSDP. Okay, so now we go to what's known as the critical variant. So this is the one that I think is particularly important because this is very, very dangerous to the surgeon who's not aware of it. Now, I think this is an article that is very useful. What they did is they developed like a nice mnemonic to describe some of the things that you should look for on a CT, and then you can, it's like a system to look at, and then you can tell yourself that, okay, I think I've looked at, or at least excluded most of the important critical variants. So it describes CLOSE, cruciform plate, laminar or nodal cell, sphenoid sinus, and anterior hemoid artery. I'll go through each one by one. So you all know about Kira's classification. It describes the depth of the olfactory fossa, or the height of the lateral lamella of the cruciform plate. So the one that's important to know is type 3, because if it is a type 3, it is a greater risk of fracture during FES. And if that happens, then you can even get intracranial penetration. Also very uncommon in my limited experience to see this. The next one is L. It is laminar papyracea dehiscence. Now, if you look at this CT, right, you can see bone here, you can see bone here, but there is no bone here. Can you see that? Bone, no bone, and bone. Okay, so this structure is a laminar papyracea. Can you see this is fat, and the fat has gone inside into the ethmoid SL. Can you see that? Fat going inside into the ethmoid SL. Okay, so this is an example of dehiscent laminar papyracea. Now, this is very important because if a surgeon happens to be in this area and they muscle this area, it can be quite catastrophic because it can cause orbital penetration. Now, you can get this from trauma, or you can also get it congenitally. I've only seen, in my experience, maybe 1 or 2 cases of congenital dehiscence of laminar papyracea. And yeah, if I see those, definitely they are worth reporting. But in terms of trauma, also seen a couple of cases once in a while. So in these patients, what they tend to get is either laceration to the medial rectus muscle, or they can develop orbital hematoma as well. Okay, this is an interesting one. So if you look at this, is the infraorbital foramen. It carries the infraorbital nerve. And you look at this one, in fact, the canal is not quite in the normal position. And I think on another view, you can see that there was some dehiscence of the infraorbital foramen. Again, this is something that I've never seen in my life. I think this is from an article. So yeah, just something to look at for fun lah. But I've never seen this in my life. Okay, although these cells are pretty common, and so what they are posterior ethmoidal S cells that extend above and posterior to the sphenoid sinus. So this is the sphenoid sinus here. So this is an ethmoidal S cell. You can see that it goes above and the sphenoid sinus. And in fact, it's pneumatizing the clinoid process here. And on coronal view, they are quite easy to identify because if you look at the coronal view of the sphenoid sinus, you should only see one vertical structure coming down at most. You should never see anything that is horizontal across the sphenoid sinus. The moment you see something that's horizontal, you're probably dealing with a nodal cell, because what you're seeing is the separation between the nodal cell and the sphenoid sinus itself. So when you do a coronal and you see something horizontal, think whether you could be dealing with a nodal cell. And then you can go to the sagittal view and see whether you see a cell that goes above the sphenoid sinus from the posterior ethmoid. Okay? They are important because they often pneumatize the clinoid process, and you know that that's next to the optic nerve. And so there's sometimes a danger of injury there. So hyperpneumatized posterior ethmoid S cell, often at risk, and if you're not aware that it is there. I think sometimes, from what I understand, you may enter and think that you are in the sphenoid sinus, when in actual fact you are in the nodal cell. I'm not sure how that occurs. Maybe you can explain to me why. But being aware of this variants would really help, I think, in deciding what's going on during the surgery. Okay, so Sphenoid sinus pneumatization is something that yeah, so there are generally three ways of looking at it. So either it's conical, where it stops before the cellar, or pre-cellar is when it's just touching the anterior part of the cellar, and then cellar is when it goes behind the dorsum cellar here. Okay, this is somewhat hyperpneumatized. Now this is an example where the dorsum cellar itself is also pneumatized. And again, if you're not aware of this, you could lead to penetration of the posterior wall and maybe CSF leak. So this patient has a very hyperpneumatized sphenoid sinus that you can see. So it has everything. You got pneumatization of the anterior thoracic processes. You have lateral recesses here. In fact, the foraminal rotundum are almost like floating inside a lot of pneumatization. So when you're poking around here, you want to be careful about that. You have a cellar type of pneumatization. The dorsum cellar is pneumatized, and here you have even the pterygoid processes are pneumatized as well. So this is a very hyperpneumatized sphenoid sinus. Some people call that type of foraminal rotundum endosynal, meaning it's actually passing through the sinus. Yeah, I think we've gone through this, so we don't have to go through this. Occasionally, and again not very common, you can see what could be potentially very scary, a dehiscent carotid canal. So you can see here, the carotid canals tend to protrude a little bit into the sphenoid sinus. They should have bony covering all over them, but you can see that this one is not completely covered by bone. So this could be highly, highly scary if you're not aware of this. Okay, this one. Alright, so this one, okay, if you guys know what the anterior ethmoidal artery is, anterior ethmoidal canal, you know what that is, right? Okay, good. I think breakfast should be coming up soon. You can see everybody nodding off already. I will be ending very soon, so just a couple more slides. So normally, right, on coronal view, the way that I look for the anterior ethmoidal canal is to look for the notch, okay? Some people will call it the nipple, yeah, you can call it that if you want, but I call it the notch. And so when you scroll through the coronal view of the lamina papyracea, you should see bone always all the time. But when you start to see the little bit of absence of bone and it goes in almost like to a notch the canal, you know that you're at the area of the anterior ethmoidal canal. Now, this is a surgical landmark for you guys, I believe. And normally it should be at the base of the skull, nicely there. Sometimes what you see is that it is actually below the skull base. So you can see that there is maybe some supraorbital cell here, and the anterior ethmoidal canal is actually below the skull base. Now, this is known as the anomalous cause of the anterior ethmoidal canal. Important because some people have described that because basically the artery is now traversing through pneumatized ethmoid cells. If you're not careful, you can actually injure the artery and tetaric the whole thing in, and you cause like massive orbital hematoma. That's something that has been described now. Okay, supraorbital cells you know about. Again, here is the anomalous ethmoidal artery. I think I don't need to go through this. You guys will be quite conversant with this. Okay. So, yay. So I think I'm done for this talk. So again, the way that I would find very useful to look at these sinusitis is to look for, firstly, a classification pattern, the drainage pathways, whether they're patent or not, variants, both the anatomic ones and clinical ones, and it's useful to use the closed mnemonic so that I'm going through everything. And finally, can look at the soft tissue as well. So, Oh, okay, never mind. I will go through this. So let's go back to the sinus CC just now and see whether you can see more stuff. Let me look for. Okay, so why don't you shout out what you see the moment you see it? Then you can impress Prof. Asma. Okay, the nasal valve is maybe a bit narrow on the right side. Okay, maybe. But you should be able to see something right about now. Haller cells. Can you see them? So bilateral haller cells, okay? And you should be able to see something around about here as well. Pneumatized uncinate processes? Can see? Yeah, clever. Okay, so this is the crystal galli, and sometimes that can be pneumatized also. Okay. Okay, anything? You should really see something else here too. Maybe a concavulsa on the left. Okay. Yes, deviation nasal septum. Yeah. And the spur, excellent. You can see a nice spur there, isn't it? Okay. Anything else?
The cyst.
Actually, there was something that you probably should have seen round about here. Yes. Can you see something else? Yes, excellent. You can see the anterior amoral artery here, right? And it's not at the skull base, it's anomalous. It's a little bit lower. Maybe some supraorbital cells here. So this one also could potentially be a problem. Okay. I think. Okay, so now we're going backwards to the sphenoid sinuses. Do you see anything? Yeah, the anterior climb process is pneumatized in this case. There is somewhat of a lateral recess as well. Yeah. So yeah, that one could also be a problem. Okay, I think that's pretty much it lah. Okay, so you can see that this patient there are multiple like bombs, as it were, if you were to do some kind of surgery. Excellent! I'm so happy you guys could see everything. So looks like I did something good. Okay, any questions? Because I think it's almost time's up for me. You guys again? Okay, if not, thank you very much. Yes.
Can you show us regarding where to look for the cribriform plate?
Oh, okay.
Sometimes they will say that the cribriform plate is lower than the normal one. So can you show in detail?
Yeah, so I would also look for that on the chrono view. Okay, so chrono view shows you the cribriform plate usually quite well. So these are the cribriform plates here. So if you come from anterior, this is the crystal galli. And then the moment we go a little bit behind, you start to see these two rounded structures, which is the olfactory fossa. They contain the olfactory bulbs. And then here is particularly nice example of the cribriform plate, but it's not often that nicely seen lah. Because it is a very thin bony structure after all, so it can be a little difficult to see, but in this case it's quite nicely seen. You can see that the plate is here. That's the
Lateral.
I think the fovea ethmoidalis.